We'll briefly review. There's a refinement in terminology and classification, and also we'll discuss few precursor lesions like dysplasia and U-pump, grading, staging, a brief mention to urine cytology. I know this is a pathology and cytology meeting. I'm not a cytologist, and I will not spend any time on molecular subtypes since others have already discussed them, and again, there's not enough time. So let's see the serial structural reorganization. So this is a microphotograph on the left side of the 4th edition of the WHO. It was published in 2016 with the classification of tumor of the urinary tract on the right side. So this is the past, and this is now the new classification. So the comparison between the 4th edition series on the left side and the 5th edition on the right side of the screen. There are a few things that we're not going to discuss that were changed, like neuroendocrine tumors, melanocytic tumors, mesenchymal tumors, and also tumors of the lymphopoietic system are not included any longer under the GU. Those are all handled in separate chapters, so that all the GU lesions are combined in the same category. So we're not anymore divided in each subspec in each organ system. The miscellaneous tumors, you can see that there are same changes on the blue arrow, it's kind of far from here, but these are the carcinoma of Schinke, copper, and liver gland. These now have a specific category under urethral accessory gland carcinomas. And another change that I want to point out is the tumors arising in the bladder diverticulum and also the urachal, that now are both in the same category for urachal and diverticular neoplasms. So in terms of terminology and classification, so the most important change is that in the past we used the word variant. Now in the 5th edition of the WHO, this term has been replaced by subtype, for a distinct clinical and morphologic category within a tumor type. So the term variant is reserved for genomic rather than morphologic alteration. So in terms of urothelial carcinoma, now we're discussing subtypes. Those are morphologically distinct and have prognostic significance, so they have implication for management. So this is a comparison between the 4th and the 5th WHO classification. You can see that again, the histologic variant now is under histologic subtypes. In terms of subtypes, most of the entity were already included in the 4th edition, but one of the changes is that nested before included also the large variant. Now these are in 2 separate categories, and the microcystic also includes the tubular. Plasmacytoid also a change in name, because before it was plasmacytoid with signet ring and diffuse. Now it's only plasmacytoid. And the clear cell is now clear cell glycogen rich. Also included in the 5th WHO, they were also present in the 4th, but under different nomenclature, is the urothelial carcinoma with squamous, glandular, and trophoblastic differentiation. Those are now recognized as divergent differentiation. So now the WHO recognized that every urinary tumor, urothelial carcinoma, can display multiple different subtypes and also divergent differentiation in adjunction to the conventional urothelial carcinoma. It's important both to list and to attempt to quantify each component, each variant, or subtype, I should say. So just a brief review of 3 of the entity, the nested, tubular, and macrocystic, and large nested, since they've been separated now. So the nested is a tumor that we're familiar with for a long time. The first was described in 1989 and also in 1982 as cancer resembling von Brunn nest. Those, in fact, are tumors that have very variable morphology but very bland overall cytologic architecture and cytologic atypia. They represent less than 5% of bladder tumors, and on cystoscopy they may have different type of presentation. They may be either flat, papillary, or also present as a bump. Now, they're characterized by small clustered nests of urothelial cells that are usually irregular, different in size and shape, and they tend also to fuse and anastomose and confluent with one another. Now you can see in this microphotograph that the lesion is not just confined to the lamina propria, but actually infiltrate between thick muscle bundles of the muscularis propria, and that's one of the diagnostic features. Now histologically, these tumors are difficult to diagnose because they have very bland cells with only focal moderate atypia that is much less prominent on the surface, so if you're handling a biopsy, it's very difficult. The overlying material can be normal, so there's no evidence of carcinoma in situ that may guide us. And usually, though, there is a deep irregular infiltrative pattern, and that's what you're looking for to make the diagnosis. And of course, the identification of muscularis propria involvement is diagnostic. And here just a couple of microphotographs of example of nested variant of urothelial carcinoma with the variability in the nest size and shape, and also the fusion, where now they're making up like ribbons. And in this microphotograph, you can see that these tumors may have sometimes also cystic changes, so the nested and the microcystic can coexist. And you can see in the right side of the screen that now some degree of atypia is more visible with binucleation and also some degree of hyperchromasia and irregularity of some of the nuclear contour. Now, of course, this is the diagnostic slides photograph where these nests irregularly infiltrating between thick muscle bundles of the muscularis propria. So deep irregular infiltrative pattern and identify muscularis propria invasion gives it the diagnosis. Now, the tubular and microcystic, they're also closely related to nested, probably I should say they're my cousin. They have bland cell lining, small either tubular or microcystic structures. The main differential diagnosis here is with cystitis cystica. However, similar to the nested subtype, these tumors deeply infiltrate in the muscularis propria, and that's the diagnostic differential diagnosis with mimickers that usually are, they are confined to the surface of the urothelial mucosa. Urothelial markers are typically positive, both GATA3 and P63. And here are a couple of microphotographs. On the left side, the tubular subtype, and on the right side, the microcystic. Now, the third entity that I will discuss is the large nested urothelial carcinoma. This is another bland tumor, cytologically in appearance. So it's deceptively benign looking, but there is a pattern of invasion with large nests. The main differential diagnosis is with urothelial carcinoma, non-invasive with inverted features. Now, the cases reported in the literature, more than 50% showed extravesical disease, so involvement of the full wall of the bladder, and also in some cases these are mixed with nested, small nested variant and large nested variant. 20% of the cases had recurrence or metastasis, and a quarter of the patient died of disease. In terms of immunostains, these tumors are very similar to other conventional and nested urothelial carcinoma. So here are a few microphotographs showing these large nests that are infiltrating again within the muscularis propria. And you can see here the nests have a very irregular contour. Sometimes they induce desmoplastic reaction. Other times they may have small round edges like in the left side of the screen. In terms of cytologic atypia, may be very bland, as you can see, on the right side of the screen. Well, there you go. So, in terms of differential diagnosis, the differential diagnosis is mainly with non-invasive low-grade papillary urothelial carcinoma with inverted pattern. And actually, in some cases, that is the superficial component of this tumor. So if you look and you have enough depth in your biopsy or transurethral resection, you may find area where there are large nests infiltrating in the muscle. So in that case, you can make the diagnosis of large nested urothelial carcinoma. Now we switch gears and we talk about precursor lesion, dysplasia, and UPAM in the 5th edition. So you can see here we're going to focus on the bottom portion of the left side of the scheme. These are the non-invasive urothelial neoplasm in the 4th edition, and on the right side you have the corresponding in the 5th edition. And there are two entities that we're going to discuss because there are the two that they're no longer present in the 5th edition. One is urothelial proliferation of uncertain malignant potential, or UPAM, and the other one is urothelial dysplasia. So the question is, should urothelial dysplasia remain an entity? Well, the term has been greatly debated. There's a lot of difficulty and in terms of disagreement among different pathologists. The definition of dysplasia in the urinary tract is not a synonymous of intraepithelial neoplasia like in other organs. And also the lesion is really a lesion that encompasses changes that are thought to be preneoplastic, but they are short, both cytologically and architecturally, for a diagnosis of carcinoma in situ. So it's really a diagnosis that we use when we're not certain about carcinoma in situ, but we don't think is reactive. And that's why there's a lot of variability among pathologists. So let's define then carcinoma in situ. Carcinoma in situ is the presence of cytologically malignant cell, regardless of the quantity, in the urothelium. There's no need to be full thickness. Actually, in some cases, maybe just pagetoid spread. The spectrum of atypia and the cell size is what is diagnostic. And the umbrella cell layer may not be present if it's full thickness, but if you have, urothelial carcinoma in situ with pagetoid spread, the actually umbrella cells may be present and still. Carcinoma in situ cells, typically we said, are 5 times the size of stromal lymphocytes compared to normal urothelial cells that are 2-3 times the size of lymphocytes. There is nuclear enlargement, hyperchromasia that you can see even at 10x. And usually, occasionally, these cells may be very discohesive, and that's the reason why you will find it easier in urine cytology, because they tend to disaggregate from one another, very discohesive. And they're also responsible for denuding cystitis. So there are 5 well morphologically recognized patterns of non-glandular carcinoma in situ. On the left side of the screen, you have the large cells with pleomorphism. In the middle, the large cell without pleomorphism. The small cell that is actually a misnomer. So this has nothing to do with small cell carcinoma. The cells are smaller, but realistically they're more compact, so they look more hyperchromatic. If you look actually the size of the cells, they're still larger than the lymphocyte. So they made probably the criteria, maybe not 5 times, but maybe 4 times. The other 2 patterns are the clinging and the pagetoid or undermining. So these are the well-defined different type of carcinoma in situ. Now, urothelial dysplasia is everything that falls short of a diagnosis of carcinoma in situ. Now you can see here there is some variability in the size of the cells, but they're not as large as what you need to make a diagnosis of carcinoma in situ. There is some degree of variability, so these cells stand out. So if we were in a papillary structure, you think about low-grade urothelial carcinoma. So that would be the equivalent on a flat side of dysplasia. Here another couple of microphotographs, again, where there's variability in nuclear size, but they don't meet the criteria for carcinoma in situ. So what is the recommendation for the 5th edition of the WHO? So there is lack of agreement on concrete morphologic criteria, so there is a poor diagnostic reproducibility. Immunostains usually are not helpful to distinguish dysplasia from carcinoma in situ. The significance is difficult to assess, predominantly because there's a lot of variability for this category. It includes a lot of things, reactive, and maybe for some pathologies, carcinoma in situ is included in the dysplasia. There's lack of reproducibility, and so there's need for longer follow-up. So the consensus in the 5th edition is that while the term is preserved, this entity does not merit any independent recognition, so is mentioned under carcinoma in situ for potential use for lesions that fall short, as we already discussed. So what the next things that we're going to discuss is UPAM. I don't know who comes up with those acronyms. Anyway, it stands for urothelial proliferation of undetermined malignant potential, but also almost sounds like a bad word. So UPAM was introduced in the WHO 4th WHO edition, encompasses lesions that previously were referred to as papillary urothelial hyperplasia, papillary urothelial hyperplasia with atypia or with dysplasia. And this is characterized by this tented architecture, almost as if you pinch the urothelium and you pull it up, but not enough to make a papilla. So they're very short, non-branching, covered, pseudo-papillary architecture most of the time. They don't have a true vascular core, covered by kind of mildly atypical urothelium. So they're considered a precursor of non-invasive, low-grade papillary urothelial carcinoma. So this is a couple of examples of what would fit in the category of UPOM. As you can see, the overall surface of the bladder is bumpy, or tenting. You can see that there is, also like an attempt to make a papilla with not really a true vascular core. There's some thickening in terms of the layers, mild atypia that is not enough to even go to the level of dysplasia, not enough to call it a papillary lesion. So this was the definition. Now the WHO 5th edition has agreed that it is no longer recognized this entity, so UPOM is gone. So this is considered early, non-invasive, low-grade, or a shoulder lesion instead of using this acronym. So one less thing to worry about. Now we're moving to grading, staging, and a brief mention to urine cytology. So grading has been proposed for a long time, since 1998, and the current grading actually was also included in the WHO 3rd edition that was published in 2004, and in the 4th one in 2016. Grading is based on architectural and cytological disorder, and closely reflect two main molecular pathogenesis in urothelial carcinoma pathways. And there's clinical relevance, and we will see in a few minutes. Now, on the right side of the screen, there is the current classification on non-invasive urothelial neoplasm. So you can see that includes urothelial papilloma, inverted urothelial papilloma, and then you have papillourothelial neoplasm of low malignant potential, non-invasive papillary urothelial carcinoma, low grade, non-invasive papillary urothelial carcinoma, high grade, and then of course the flat lesion that we already described, urothelial carcinoma in situ. So this is just a comparison for the WHO 1973 that was used in prior. The grading included papilloma, transitional cell carcinoma 1, 2, and 3. Now if you transfer to the 2004, the papilloma is still there. The transitional carcinoma in situ 1 is the pon lump, but can also go into low grade. And then the 2 is the low grade, but can also go into high grade, and 3 is high grade. Now, as you can see from the table underneath, there is actually implication for this type of grading. First of all, the distribution is different, the recurrence rate for those papillary lesions is different, and also the progression that is low to inexistent for a papilloma, of course, and up to 25% of the cases for high-grade papillary urothelial carcinoma. Now, this is a table that summarizes all the features that we use to distinguish between papilloma, papillary neoplasm, low malignant potential, low-grade urothelial carcinoma, and a high-grade urothelial carcinoma, and includes both architectural, both as a papilla and the organization of the cell, and the cytology, including nuclear size, shape, chromatin, nucleoli, mitosis, and umbrella cell. Of course, we don't have the time to review, but this is what we use as criteria. Now, why is important? There are studies showing that indeed, when you use these different stratification, this matters in terms of recurrence, cumulative, incidence, but also you can see that these discriminate very well between the pon lump, low grade, and high grade in terms of progressive, cumulative incidence and progressive mortality overall. These also have been included in the NCCN guidelines, and in fact you can see here that depending on the type of grade of the lesion, you will have a stratification for non-muscle invasive bladder cancer. So if you have a pon lump, this will be a low risk, And intermediate risk include both the low grade and the high grade, depending on the number of the lesion, the focality, and also the size. And then, of course, the high risk were included the high grade urothelial carcinoma. So now in the WHO 2022, the 5th edition, remained the 3 tiers classification, and that we have already discussed, and also the 2 tiers grading. So similar to the previous one, no changes. In terms of heterogeneity, now heterogeneity in grading occurs in about 1/3 of non-invasive papillary urothelial carcinoma, and this is something that sometimes we struggle with, does influence outcome, how much is enough to bump it up to a high grade if you have a portion that is low grade. Well, the WHO 5th edition has proposed to report a lesion as high grade if the high grade component represents equal or more than 5%. If it's less than 5%, that high grade component, then the lesion should be reported as low grade with less than 5% of high grade. Sometimes I use the term low grade with focal high grade. So this is a pragmatic approach, and it's important to increase consistency in grading in view of this heterogeneity of tumors. And this would allow, actually, if we all apply these criteria, to collect further data that may help, powering study for the future, so that we are comparing similar population of patients instead of comparing probably apple and oranges. So in terms of grading of invasive urothelial carcinoma, now the majority of invasive urothelial carcinoma are high grade. I don't call anything low grade, but there are low-grade invasive urothelial carcinoma that lack significant nuclear atypia. They are recognized in their publication. Now, there are no standardized criteria, and the outcome is still probably up for discussion. So the 5th edition of the WHO required to grade every invasive urothelial carcinoma, and the histologic subtypes of urothelial carcinoma and divergent differentiation are all considered high grade. And so for me, if the tumor is invasive, I will call it high grade. So in terms of staging, few words for PT1 subcategorization, because otherwise there's no major change in staging of urothelial carcinoma. Now the substaging is a very hot topic, and Dr. Comparat gave a nice presentation today. So the extent of lamina propria invasion carry prognostic value. Now the issue is, how are we going to evaluate that subcategorization? Few things have been proposed. You can use a micrometric measurement, so it's either microscopic versus extensive, or you can use histoanatomic landmarks like the muscularis mucosa versus the vascular plexus, or micrometric, that is probably more feasible and better predictor, potentially. Probably more studies are necessary. Now, the higher subcategories correlate both with the recurrence and also with stage progression. So the recommendation for the WHO 5th edition is that well-designed prospective studies are needed. The pathology are strongly encouraged to convey the extent of lamina propria invasion using any of the proposed approaches, but they don't recommend any one in particular, so you're left with your own devices. This is one of the cases that I wanted to show to you. So this is a case where there is a focus of small area of invasion of the lamina propria. I hope you all agree. So this would be focal, but if I had to take a measurement, would be, much less than a millimeter, so probably like 0.2 millimeters. On the other hand, this is a tumor that invades all the full thickness of the biopsy, so this will be extensive and is about 2 millimeters in thickness. So if the biopsy is well oriented, I attempt to give an idea of the thickness. So in terms of staging, another thing that is important to at least mention is the urothelial carcinoma invading prostatic stroma. And there are two types of invasion that can occur. One is contiguous, when the tumor actually directly invades from a transmural involvement of the bladder wall and goes down into the bladder, into the prostate, as you can see here. So you have a large tumor that invades full thickness the bladder and then goes into the prostate. That is staged as T4. But if you have a tumor like in this microphotograph that invades the prostate coming from the urethra, we're going to use the urethra staging. So this will be a T2. So of course, if you're dealing with a transurethral resection, you don't know which one are you dealing with, so you cannot stage these tumors. Now the WHO 5th edition also, there are studies suggesting that there may be difference gender specific between the T4 disease in male and female, but for the time being, the WHO 5th edition maintains a single category that appears to be the optimal approach at the present time. Things may change in the future. Urine cytology. Cytologists in the audience, this is your time to shine. This is the only slide on cytology. Not because it's less important, just because I don't know anything about it. So the Paris system is what is recommended for urine cytology, for reporting cytology. This has improved significantly accuracy and also acknowledged the inability to reliably detect low-grade urothelial neoplasm. And in fact, low-grade urothelial neoplasm encompasses both the papilloma, the pond lump, and the low-grade urothelial carcinoma. But the system also prioritized the importance of it identifying high-grade lesion. So high-grade urothelial carcinoma, the WHO endorsed and recommended the adoption of the Paris system for reporting cytology. So take-home point for the bladder. Now urothelial dysplasia is on its way out. U-pump is gone. Invasive urothelial carcinoma subtypes and divergent differentiation should be recognized and stated in your report. There's many flavors of nested subtype of urothelial carcinoma, all bland looking, but with aggressive potential. WHO grading is maintained, survived the WHO 4th edition, and the PTOA staging should be attempted. Now we switch gear to one of my favorite organs, the prostate. So let's see, we trying to follow the same approach, but we have already done some work, so we're not going to spend much in terms of structural reorganization and terminology and classification, but we're going to adapt it to the prostate. So here now is the same version of the WHO 4th edition on the left side and the WHO 5th edition on the right side. You can see that they're similarly to what I said before. There's a lot of things that are handled in separate chapters, miscellaneous tumors, metastatic tumors, neuroendocrine tumors, except for a treatment-related neuroendocrine prostatic carcinoma and also hemolymphatic lesion. Now, the other things that are included in the prostate chapter are mesenchymal tumors unique to the prostate. All the other tumors that are shared in other organs are dealt in a different chapter altogether. And the other things that I want to point your attention is the squamous cell carcinoma of the prostate. And last but not least, the basal cell carcinoma that was called basal cell carcinoma in the 4th edition. And now, to uniform with the other organ system, is called adenoid cystic basal cell carcinoma of the prostate. Now, similarly, we have already discussed the variant versus subtypes. So for the prostate, the subtype of prostatic adenocarcinoma are morphologically distinct and have prognostic significance. And let's review some of those. So on the left side, the 4th edition, on the right side, the 5th edition, and you can see in red, we don't use the histologic variant. Now, most of the lesions that were included under histologic variant are called unusual histologic patterns. So if you can see, you can just transport most of them, just the same entity, under different category. And then we have included also histologic subtypes. So if you take an arrow and you point from the arrow, everything below the arrow goes now in histologic subtypes. Signal ring-like cell adenocarcinoma, pleomorphic giant cell adenocarcinoma, sarcomatoid carcinoma, and the new entity that has been included is the pin-like carcinoma that was previously considered a variant of ductal, now instead is considered an histologic subtype of acinar. So this is just a microphotograph showing you the unusual histologic pattern, foamy, you have atrophic, pseudohyperplastic, and microcystic all in one shot. The only thing that is missing is the mucinous, sorry. And here's the histologic subtypes, just for a brief introduction. The signal ring-like cell, and then you have your sarcomatoid, pleomorphic giant cell, the pin-like a pin-like carcinoma that, as I mentioned, was previously under ductal. Now, let's discuss briefly the pin-like carcinoma, since it's a new entity. This is uncommon. It's a tumor that resembles actually high-grade pin or ductal adenocarcinoma. Typically, it's characterized by these large, cystic, discrete glands that may be at the periphery of a needle core biopsy, but they're very large. They have a flat lining. Sometimes they have this sort of short papillae or little tufts architecture, similar, if you remember, Bostwick scheme for high-grade pin, the either flat or tufted. They're characterized by pseudostratified epithelium with elongated nuclei, and I'll show you a few microphotograph. The main differential diagnosis is with high-grade pin. Of course, the glands are more crowded, there's lack of basal cells, so that's the key features. So if you do your basal cell markers, they will be negative. Ductal adenocarcinoma, but the absence of true papillary architecture with vascular core and of cribriform glands and necrosis is the main differential diagnosis. Generally, these pin-like carcinoma have a good prognosis. So in terms of graded, they're graded as Gleason score 3+3=6, so grade group 1. Although there are some publications showing that if they start having papillary projection, maybe they're gonna behave more like 3+4. I don't think the jury is out yet, and there's probably not enough data. Molecularly, they frequently have inactivation, activating mutation of RAF and RAS pathway. So here is actually the first case that I've seen that was seen in consultation, and the outside pathologist thought was high-grade pin. Not much damage was done because the patient had cancer in other biopsy, but you can see that this is a very hyperchromatic lesion. There's very large glands, larger than what a normal pin-like gland would be. They're also crowded, there's prominent stratification, and the basal cell marker also was negative. So this is another example on a biopsy. Probably the minimum I've ever diagnosed. You can see that there's a very large gland at the edge of the core that is completely negative for basal cell marker. The internal control is present in the two glands that you have at the left side of the screen. And this is another example where there's more like of, some of these tufting and flat architecture of the glands with stratification of the nuclei, completely lack of basal cell by P63. And just to show you the morphology, you can see very nicely here the stratification of the nuclei, the presence of large and elongated. That's why originally was thought was a ductal variant, because they're taller, the nuclei, more oval, and the stratification, and of course the lack of basal cells. So now, should ductal adenocarcinoma become a subtype of acinar? This was also considered during the brainstorming of the 5th edition of the WHO. However, the overwhelming majority admitted of these tumors are mixed with acinar. Genomic studies have shown that they are clonally related and there is concurrent acinar adenocarcinoma. However, these tumors seem to be relatively enriched for both germline and somatic pathological alteration in DNA repair genes. And also the ductal histologic features are often preserved in metastatic sites. And these tumors tend to metastasize in a different pattern than your typical acinar prostate cancer. So it was decided that maybe it's better to maintain it as a separate type. Now, to report a tumor as ductal on radical needs to require at least 50% of the tumor needs to be ductal, otherwise it would be mixed. On a biopsy, because you don't know the appropriate terminology is adenocarcinoma of the prostate with acinar and ductal features, or if it's predominantly ductal, just with ductal features. So the 5th edition consensus is to keep ductal adenocarcinoma as a separate type. This is just a few examples on the left side of the screen, an example of ductal adenocarcinoma of the prostate with true papillary architecture and vascular core. On the right side, the cribriform pattern that has more like slit-like spaces instead of like punched out holes that you can find usually in acinar adenocarcinoma. Now here, a few more examples with the papillary architectures and the combination of both, cribriform and papillary and cribriform. So now let's review a few precursor lesions that have, been some changes in the 5th edition of the WHO. The first thing is high-grade pin. So the changes is that this is the earliest histologic recognizable precursor. Low-grade PIN and cribriform high-grade PIN are no longer regarded as distinct entity. So we don't recognize low-grade PIN, and for high-grade PIN you have only 3 patterns: your tufting, micropapillary, and flat. So the cribriform is gone. So we don't call it any longer cribriform high-grade PIN. So typically these different patterns coexist. You can see here both flat, micropapillary, and tufted together. The characteristic cytologic feature is the presence of prominent nucleoli, 20X, and the stratification of the nuclei. Now, what happened to that cribriform high-grade PIN? So now it's been repurposed, so it's been called, most of those lesions, atypical intraductal proliferation. So those are intraductal proliferation that architecturally and or cytologically are more complex than high-grade PIN, but they fall short for the criteria that you need for intraductal carcinoma of the prostate. So the other terminology that was used also is atypical cribriform proliferation, atypical intraductal proliferation, suspicious for intraductal carcinoma in situ, when you don't have enough criteria to go all the way for carcinoma, intraductal carcinoma of the prostate. So then this is the use of the terminology atypical intraductal proliferation. So this is an example of a lesion that in a radical prostatectomy in the past would have probably been called cribriform high-grade PIN. Now this will be atypical intraductal proliferation. Now, of course, you have to prove that the basal cells are retained. Now let's introduce the intraductal carcinoma of the prostate. This is an entity that was already recognized in the 4th edition and is defined by malignant secretory cells that grow within and expand prostatic duct and acini. These entities associated with adverse prognostic feature at radical prostatectomy, both high-grade, large tumors, extraprostatic extension, seminal vesicle involvement, and is an independent predictor of clinical outcome. So there are 2 types that are recognized in the WHO 5th edition. So 2 distinct entities. On the left side of the screen, the less common one that is quite rare. This is isolated high-grade PIN, so the isolated intraductal carcinoma of the prostate. There is no invasive cancer, but there are these lesions that are, again, intraductal carcinoma of the prostate. This is likely a precursor from high-grade PIN towards the intraductal carcinoma. And on the right side of the screen, the other form that is the much more common, that is invasive prostate cancer that spreads into benign ducts and acini. So this is considered like a retrograde filling of benign prostatic glands and acini by an invasive cancer. This is a late event in tumor progression. So what are the diagnostic criteria? As I mentioned, is the spanning of large acini and duct by malignant cells, and there is preservation of basal cells. So your basal cell markers will help you to distinguish these from invasive carcinoma, but will not help in the diagnosis of intraductal carcinoma and distinction from your atypical intraductal proliferation. So let's review the criteria. You can have either solid or dense cribriform architecture, where more than 50% of the lumen is filled by epithelium. Or you can have loose cribriform, where there's less than 50%, or micropapillary. If you are in this category, you need additional criteria. You need comedonal necrosis, non-focal, or marked nuclear atypia with nuclear size larger 6 times than normal. So, few examples. This is an example of intraductal carcinoma of the prostate, solid type. This is probably easy to recognize because when you do your basal cell marker, if the basal cells are retained, the main differential would be with urothelial carcinoma filling the prostatic duct, or you're left with intraductal carcinoma of the prostate. This is an example of the dense cribriform pattern where you can see that more than 50% of the lumen of the glands is filled by epithelial cells. So this is also a category that I think it's more easy to make a diagnosis. Now, the difficulties when you're dealing with loose cribriform. So loose cribriform, as I mentioned, in addition to the architecture, you need to have also either comedonal necrosis, non-focal, or the presence of large atypical cells. This is an example with the micropapillary, where you also need to have, again, the presence of large atypical cells, and you can see that there's also comedonal necrosis in the background. So these are diagnostic of intraductal carcinoma of the prostate with different pattern of morphology. Now, these are the 4 patterns altogether. Now, the 5th edition of the WHO recognized that the presence of intraductal carcinoma of the prostate should be reported, either if it's in association or isolated. Isolated intraductal carcinoma of the prostate is not very common. It's less than 1% of prostate biopsy, but should not be graded. And here there is consensus, both in the WHO and both the society agree. However, it's still controversial whether the intraductal carcinoma of the prostate should be incorporated into the grading of invasive carcinoma. And this is something that there's discrepancy between the two genitourinary society, the two society, genitourinary pathology, but also the WHO does not take a stand on this point. Why is it important to recognize intraductal carcinoma? There is clinical significance both when it's seen in isolation and when it's associated with invasive carcinoma. There is an impact for decision for therapy, for when diagnosed on a needle biopsy, and also as a prognostic factor to predict outcome. Now, grading, a few words about grading. Prostate cancer grading now, you can divide it into 3 groups, pattern 3, pattern 4, and pattern 5. These are the Gleason patterns. Pattern 3 is well-formed glands. Pattern 4 recognize 4 different patterns, so 4-4. You have cribriform, fused, poorly formed, and glomeruloid. And pattern 5, predominantly are either solid, single cells. In the past, there was also comedonal necrosis. You have to be careful. Some of those are indeed pattern 5, and then you can have solid cylinder. So in terms of grading, now the grading group system has been, we've been using it for some time. It first was described in 2013, then has been actually accepted both by the society and now has been endorsed also by the WHO. So we reported not only the grade group, but also the Gleason score together. And this has been actually a very important step forward. There's a lot of studies that have shown that this grading grouping system is able to discriminate very well the different tumors, not only in radical prostatectomy cohorts, but also in tumors that are treated with radiation and tumors that have been treated with watchful waiting. So now, what about grading for all the things that we have already discussed? So unusual histologic pattern. They're all Gleason grade 3+3 = 6, so WHO grade group 1. The histologic subtypes grading, the signet ring, sarcomatoid, and pleomorphic are WHO grade group 5. But as I mentioned before, European-like is WHO grade group 1. So in terms of grading, both society agree that it's important to report the percentage of pattern 4, at least for tumor that are Gleason score 7. The presence of invasive cribriform carcinoma should also be reported in Gleason score 7 and 8. And both acknowledge that there are some problems in terms of inter-observer reproducibility, particularly for some of the pattern 4, like the fused glands and the poorly formed, where there's overlapping with maybe tangential sectioning. I think we're more reproducible when we're dealing with glomeruloid and cribriform. But nothing is perfect. Now, there are numerous studies, and this is a beautiful review looking at the importance of cribriform morphology, and there is agreement that cribriform, actually pattern 4, is the most aggressive pattern 4 subtype, and is important to report it because it's associated with adverse outcome. In terms of cribriform pattern 4, now, there are still some concern regarding the reproducibility and the definition of cribriform, what consists small cribriform versus large cribriform. There's also some issues regarding the distinction from intraductal carcinoma without using immunostains, and if it matters in some cases. And then again, the exclusion of intraductal carcinoma from the Gleason grading that may be problematic and potentially unnecessary without more extensive utilization of immunohistochemical markers to distinguish invasive cribriform pattern 4 from intraductal carcinoma of the prostate. Now, these are two cases where you can see on the left side of the screen, of course, one could think that these large glands and irregular are invasive cribriform prostate cancer. Maybe in the past these were called pattern 4, but now actually if you do the basal cell marker, you can see that they're surrounded by basal cells, so that's intraductal carcinoma. On the right side of the screen, instead, there are glands that are intraductal carcinoma, but there's also glands that are invasive. A word of caution. Now, in the past, we would have looked at this microphotograph and called Gleason pattern 5+5 equal 10. This is committer necrosis. Next case, not so fast. Actually, this is a case of intraductal carcinoma with committer necrosis. There are studies showing now that actually you need to pay attention before you just dismiss it as Gleason pattern 5. Most of those lesions are intraductal carcinoma of the prostate. So this is not invasive, this is intraductal carcinoma of the prostate with committer necrosis. So grading, we have already discussed. This is for the GAPS publication. The only things that I want to point it out here is that the society and both society agree not to grade the intraductal carcinoma of the prostate in isolation, but the GAPS suggests not to include the intraductal carcinoma in determining the final Gleason score on radical prostatectomy and or biopsy. And that's the difference from the ISUP. Now, take-home point for the prostate. Cribriform migrate P now is either atypical intraductal proliferation or, for some cases, maybe meets the criteria of intraductal carcinoma of the prostate. The low-grade PIN doesn't exist any longer, so you don't have to worry about. The unusual histologic pattern and histologic subtypes of prostatic acinar adenocarcinoma should be recognized. Ductal adenocarcinoma is a separate type. The grading, WHO grade groups has been recognized as the preferred grading, but together with the Gleason score that is still reported. And isolated intraductal carcinoma of the prostate is not graded, should not be graded. Now we move to renal tumors. In the interest of time, there's not much that I can cover, but I thought at least I'll give you a glimpse of a few things that are in the WHO. Now, same comparison we used before. On the left side of the screen is the 4th edition. The right side of the screen is the 5th edition. Now we're going to focus only on renal cell tumors. And you can see that already compared to what was the prior classification, we have an increased number of renal tumors every day. There's some new entities. But let's see in a little bit more details what are the major changes between the 4th and the 5th. So some is repurposing, renaming. So these entities that are on the left side of the screen now in a red box, the hereditary leiomyomatosis renal cell carcinoma, associated renal cell carcinoma, it's now in the molecular defined group as fumarase hydratase deficient renal cell carcinoma. The renal medullary carcinoma now is also in the molecular bucket under the SMART-B1 deficient renal medullary carcinoma. And the MIT family translocation renal cell carcinoma is also under the molecular classification for TFE3 rearranged renal cell carcinoma and TFE-B rearranged renal cell carcinoma. So nothing new there, just in a different category. Now, these are the one, as I mentioned. The new things that are now highlighted by the asterisk are entities that either were not included in the 4th or they were as a provisional diagnosis but not fully recognized. Now they're included in the 5th edition. And one is the eosinophilic solid and cystic renal cell carcinoma, or ESC, in your keyboard of your computer, and also the ELOC, formerly known as TCEB1 mutated renal cell carcinoma, and the ALK rearranged renal cell carcinoma. And I will spend a few minutes to review those entities. So this is actually a nice table that includes all the key features of these 3 players. This is from a paper from my good friend and colleagues, Kirill Tripkov, and the rest of the GAPS group in Modern Pathology 2021. These are new entities that are included in the WHO 5th edition. And you can see that, now I don't have time to go into much detail, but there are clinical features that are important: morphology, immunohistochemical marker, and also the molecular, and overall also the prognosis that you can see it's good for the eosinophilic solid cystic, although this tumor has potential for metastasis, usually favorable for the what they call the renal cell carcinoma with fibromyomatosis stroma. This is the equivalent of the ELOC. And however, different is the ALK, that this is a tumor that has adverse potential, and actually they may be aggressive in the long term. So a few words: the eosinophilic solid cystic renal cell carcinoma, this can occur both in the sporadic setting, but also in patients with tuberous sclerosis. Predominantly in the sporadic setting occurs in female, but there are now reports also in the male. Characteristically, as the name implies, there are eosinophilic cells in the tumor solid cystic spaces, as you can see in this microphotograph, with upnailing of the cells surrounding those cysts. And most of them have indolent behavior, but metastasis has also been reported. Typically, these tumors have a very, as I mentioned, prominent eosinophilic cytoplasm. The cytoplasm is also has this clumpy material, very irregular aggregates that has been referred to as leishmaniasis. I'm not an expert, maybe you guys actually are in here, so I'm not going to teach you anything about that. Those tumors typically stain diffusely for cytokeratin 20, but not always. So sometimes they may be also focal. Now, in terms of, as I mentioned, potential, these are two cases actually that were reported as metastases. One is a 15-year-old female with a multifocal-esque eosinophilic solid cystic tumor that presented both with liver and lung metastases. And this is a case that I saw when I was at the Cleveland Clinic on a 69-year-old female that had a large tumor in the kidney and had a metastasis in a lymph node. And as I mentioned now, this tumor also been reported to be multifocal, they can be bilateral, and also occur in male. The next entity, few words regarding the ELOC mutated renal cell carcinoma, also referred in the past as TSAB1. Some of those tumors have the TSAB alteration. These are the tumors with renal cell carcinoma with myofibromatous stroma or leiomatomatous stroma. This is how they were referred also in the past. You can see that there are tumors with clear cell, but they have these very prominent fibrous band septa that divided the tumors in a multinodular appearance. They have recurrent alteration of both the tuberous sclerosis complex and mTOR pathways, and a subgroup of those tumors have this TSAB1 mutation. Most tumors show indolent behavior. Now, this fibromuscular band impart that nodular appearance that I mentioned. They are characterized by elongated branching tubules that may frequently, have also this very prominent clear cytoplasm of the cells, abundant with prominent cell membrane. Typically, they are diffusely positive for cytokeratin 7, as shown in this microphotograph, and they have a membranous positivity for CA9, so not the cup-like staining pattern characteristic of clear cell papillary renal cell carcinoma. CD10 variably positive, VHL mutation can or not be present, and tuberous sclerosis mutation also can be seen. Now, a few words regarding the ALK rearrangement associated renal cell carcinoma. There are about 40 cases documented, and actually more coming out now that we have a good marker for these tumors. This was listed in the WHO 4th edition as an emerging provisional entity. Now is a well-recognized entity in the 5th edition. There are genetically distinct entities that demonstrate a lot of heterogeneous morphology. So this tumor could be the great mimicker, a lot of different morphologic appearance. They are characterized by an ALK gene rearrangement that results in the fusion with various partners. This is a case that I've seen at University of Alabama, where the fusion was with the EML4 and ALK variant. And what happened after that fusion is the aberrant ALK activation with oncogenic chimeric protein. This ALK rearrangement can be identified both by immunohistochemistry, FISH, and also by sequencing. And this is an example of such a case that presented actually 10 years ago, was diagnosed as a papillary renal cell carcinoma. 10 years later, this is a lesion that actually presented in the lung. and then in the brain, and were considered FH, they were considered translocation, but was negative. And then after the last time in the brain, I thought, ooh, maybe this could be one of those ALK. And in fact, I did ALK1, and ALK1 diffusely positive, and then the next generation sequencing showed the pattern that I showed you before. So the morphology is very variable, but usually they're pink eosinophilic tumor. They have, could be rhabdoid, could be vacuolated, pleomorphic giant cell, name it. They may have mucinous tubular spindle cell-like appearance, small cell appearance, metanephric adenoma is a great mimicker. The Samamoto's classification can also be seen in addition to coagulative necrosis and intracytoplasmic mucin. Although most of the tumor seems to have indolent behavior, there is reported malignant potential, both metastasis and death in 25% of the cases in the adult. And I believe that the aggressive behavior is probably after a long time, like in our patient it occurs like 10, 15 years later. So the take-home message point for the kidney, 3 novel entities that were included in the WHO. One is the S-RCC, the ELOC mutated, and the ALK-RCC. And then a new group of molecularly defined renal cell carcinoma was added. And this is, I think, what we're going towards. I can predict that in the next classification, most of the tumors probably will require some molecular classification. That's how we're going. Morphology is helpful in a lot of cases. You can have an association between the molecular and the morphology, but in the future, probably we will need to prove some of those new entities. So I want to thank you for your time. And now it's time to relax, particularly for me. And I think it's time to drink wine and enjoy the rest of the meeting. Thank you very much.